Can you see my screen?
Looks good.
All right. So I'm going to talk about theranostic power of radioactive iodine. The issue brought up by Marcus, theranostic or theragnostic. I'd like to make a quick comment. Theragnostic reminds me agnostic, so I really don't like it. We either know or don't know, but never agnostic. So I'll stick with my theranostic term. I hope I don't offend Doug by making this comment. Well, I think it's time to clarify certain terms. What is theranostic power? What's theranostic profile? And what's theranostic performance? Theranostic performance is the term that describes ultimate clinical performance. And that depends on technical issues, optimizing the technical factors, which I call theranostic profile. Theranostic power per se refers to the intrinsic biological factor in any cancer theranostics. In particular with radioactive iodine, it's the tumor biology that allows tumors to handle radioactive iodine. In general, to maximize the theranostic or therapeutic power, one should dissect out the factors involved prior to engaging in the treatment. I have issues with blind radioactive iodine treatment. Even if you see some things at the end, even if you see some drop in thyroglobulin, that does not necessarily translate into clinical performance in terms of clinical outcomes. Enhancing the therapeutic power, tumor biology, reversal of radioactive iodine indifference via MAP kinase ERK pathway modulation, clinical protocols to optimize the radioactive iodine uptake, dosimetry. These were covered by Drs. Van Nostrand and Loster, and imaging technology and maximizing the spatial resolution and quantitative accuracy. These were also covered by Dr. Van Nostrand and Loster, and I will say a few words at the end of my presentation. This is obviously part of the technical factors improving the theranostic performance of radioactive iodine. This is the slide I failed to show you in my first presentation. This is a 1946 autoradiography performed by Dr. Ralston and Dr. Hertz, papillary carcinoma and adjacent normal thyroid tissue, excellent iodine concentration in the adjacent tissue with essentially no uptake in the papillary component. So this reflects the biology, and this is the intrinsic theranostic power that I am going to talk about. Same issue with the so-called microfollicular cancer. One would expect a very good uptake, but yet there is very limited uptake in the tumor compartment compared to the adjacent normal thyroid tissue. I think the radioactive iodine indifference of papillary thyroid cancer is underestimated. The theranostic and therapeutic power of radioactive iodine can be enhanced and is being used in research settings and to a very limited extent in clinical settings by MAP kinase ERK modulation. This oncobiologic intervention is applicable to all follicular cell origin cancers in which the functional dedifferentiation is dominated by this ERK output. And this was nicely, Dr. Hertz, once again, I salute Dr. Hertz in vision and insight that he noticed early on that the cancer cells were biologically quite different than the normal ones, and the hyperplastic thyroid cells of Graves' disease, which are very readily and successfully treated. Now, there is a wonderful experimental thyroid tumorigenesis model created by Dr. Fagan's group. This model illustrates the oncologic and oncogenic events and how they translate into thyroid differentiation and expression, the best expression of thyroid differentiation in terms of radioactive iodine imaging. This is done using this special mice and a model that is a doxycycline-induced BRAF induced papillary carcinoma model. This upper left corner shows small, tiny, normal thyroid gland in mouse, and a weak doxycycline treatment, it gets bigger, highly vascularized, turning into a BRAF positive cancer. Then in the second row, you see once you stop doxycycline, as early as 72 hours, the tumor starts shrinking. By the time 2 weeks, it's smaller, and 7 weeks later, it is back to the normal size. Looking at the histology, uninduced histology shows nice follicular pattern of normal thyroid gland. But 1 week of doxycycline stimulation, you see the complete loss of normal architecture. This is almost looking like somewhere in between papillary and poorly differentiated carcinoma. Then once you stop the stimulation, oncogenic stimulation, the tumor becomes again forming follicular structures. 7 weeks off, it's back to its normal histologic pattern. Looking at immunohistochemically, Ki67 is a marker of proliferation. In a normal thyroid gland, very few positive cells, showing that most cells are at G0, not proliferating. A week of stimulation, there's intense Ki67, almost 80–90% positive in a low power field. And once you stop stimulation, it goes back to the baseline. This is also very impressive how stopping the oncogenic stimulation changes morphology and function. Looking at the NIS, sodium iodide supporter expression, uninduced, in the uninduced tissue, you have very nice NIS expression. Just a week on stimulation, you lose the entire NIS expression, and stopping it for a week restores the NIS expression back again. Same thing happens if this time you continue the stimulation, but use BRAF inhibitor on the left side. BRAF inhibitor restores the NIS expression, and MAPK inhibitor on the other side is again restoring the NIS expression, where in the middle you continue the stimulation with no BRAF inhibition or MAPK inhibition. Tumor remains with no expression of sodium iodide. It's important. This translates very nicely into radioactive iodine imaging with I-124 and small animal imaging model. Uninduced, you see the nice, intense I-124 uptake. A week on doxycycline stimulation, there's significant shutdown or a decreased uptake. With a week off treatment, just stopping the stimulation, it restores radioactive iodine concentration ability. You achieve the same end result despite the continuing stimulation. If you use a BRAF inhibitor, you have the potential to restore the iodine uptake. So with a MAPK inhibitor producing the same results. This is, I think, a best example in an experimental model how one could manipulate the MAP kinase pathway to restore the iodine handling ability to change the fortune of the cancer cells from an indifferent state to a avid state. This slide shows you the molecular profile and thyroid differentiation score in tumors with different differentiation, or I should say morphologic differentiation. On the left side, you have a follicular adenoma / microinvasive follicular thyroid cancer. Next is widely invasive follicular thyroid cancer, and this column is the PTC, papillary thyroid cancer, followed by ATC, anaplastic thyroid cancer, and on the far right, you have the normal thyroid transcript for thyroid differentiation, the molecules expressed, which we list under the thyroid differentiation score, all the enzymes involved, as well as the transport proteins. As you see in follicular adenoma, or even in the microfollicular thyroid carcinoma, most of the thyroid differentiation molecules are well expressed, but not all of them. In the lower row, you see some of them are poorly expressed. And this same pattern repeats in the microfollicular FTC. It starts losing its similarity in widely invasive FTC, follicular thyroid cancer. And in PTC, you clearly identify two categories. One is the BRAF type, and the other one is RAS type. Purple is BRAF type, where you have essentially near total shutdown or minimal expression of molecules of thyroid differentiation score. It is relatively better preserved in RAS type of tumors. In the ATC category, almost all thyroid-related transcripts are completely suppressed. Now, this shows the molecular profiles of clinically aggressive cancers. And red is BRAF and blue is RAS type of tumors. In the lower image, you see the ERK score. Higher the ERK score, lower the TDS. Lower the ERK score, higher the TDS. This is what we already presented, and this is now well known and accepted. And this translates into the morphologic identities of tumors with high aggression. ATC has a very high ERK score and very low TDS, as opposed to follicular adenoma, which has the lowest ERK score and highest TDS. This is an interesting image. What you see here is the distribution of different histology tumors on the scale of TDS from -4 to +2. Most of the tumors of the yellow squares with dark center represent ATC. Almost majority of the ATCs are in the left upper quadrant, if you will, with very low TDS, as expected. But as you see, some of them actually in the category of favorable TDS, in the same category with BRAF tumors, and even some RAS tumors, which tells us that there is, even in anaplastic carcinomas, there is the potential of tumors resuming their differentiation if an appropriate biologic intervention can be given. So those are these blue sites are the potentials for treatment. They have the treatment capability. The goal, clinical goal, would be moving those in the negative, far negative TDS into this category. That is the biologic modulation to improve the intrinsic, theranostic, and therapeutic power of radioactive iodine. And I call this a minor disparity between morphology and TDS, which works in favor of radioactive iodine treatment as it goes to the potential of this to be used in even anaplastic carcinomas where we have very limited treatment options. This is also a very interesting slide, at least to me. This is the TDS profile of Hürtel cell carcinoma. Hürtel cell carcinomas are traditionally known to not respond radioactive iodine. It's still to date a controversial issue because there are observations that it does respond. There are the majority of the observations are that they don't. Now, if you analyze this very, very carefully, morphologically, there are two types of Hürtel cell carcinomas. One is focally showing focal capsular invasion, and the other is wide capsular invasion. It's H-min or H-wide. The purple ones on the left side are Hürtel cell with widely that have wide capsular invasion. The orange ones are with minimal capsular invasion. Now, the upper part represents, in general, unfavorable TDS. And as expected, 60%, majority of this is widely invasive Hürtel cell, but 40% of minimal capsular invasion Hürtel cells also belong to this category. More important than this, in the favorable category, there is 6 out of 21. That is about almost 30%. 1/3 of the Hürtel cells have or may have favorable TDS, thus may be treated with radioactive iodine. So this again illustrates the importance and the potential importance of getting a TDS profile before engaging or before making any treatments. Now, right now, without having the routine capability of measuring TDS, and TDS not having had the clinical validation, I think these Hürtel cell patients deserve the chance of benefiting from radioactive iodine, although it's as low as 30%. So how do we do this MAP kinase modulation? Going back to our original picture, as initiated by RAS or BRAF mutation and subsequent MEK activation, ERK is activated and moved into the nucleus, and ERK has shut off the thyroid differentiation mechanisms, transcription of any of the thyroid-specific transcription factors, which is linked to expression, transcription of the molecules, enzymes, and the transporters handling the iodine. It also has activated cell cycle. The cancer cell is dividing as a cancer cell. Now, we have two different categories of MAP kinase inhibitors. One is the multi-kinase inhibitors, and then the specific kinase inhibitors. Multi-kinase inhibitors, sorafenib, lenvatinib, lapatinib, they essentially, when they bind the tyrosine kinase receptors, there is a global effect, and they turn off the cell cycle. Then we have the brafenib and vemurafenib. Dr. Van Nostrand mentioned these. They shut off BRAF. And then we have selumetinib, trametinib, and cobimetinib, these shut off MEK. When MEK is shut off, when BRAF is shut off, ERK is shut off. Once ERK is shut off, the sequence of events, number one, ERK, the ERK shut off. By the way, ERK also can be blocked. There are few drugs are being tested for ERK blockage, but not there is nothing in clinical trials yet. I think there is one at a very early stage. ERK inhibition also would turn back on the transcription factors and restore thyroid differentiation. Thus, the clinical measure the thyroid differentiation score. This is the schematic model how today we could modulate MAP kinase and ERK output. Examples of this are, this is well known to the nuclear medicine community. Dr. Ho's study published several years ago, MEK inhibitor with selumetinib before the treatment, after the treatment, before the treatment, after the treatment. This is, all these patients underwent I-124 PET-CT, then selumetinib for 4 weeks, and PET-CT with I-124 was repeated after selumetinib. Selumetinib clearly demonstrated significant improvement in radioactive iodine uptake in all the known metastatic lesions. Here is a study that looked at BRAF inhibitor, dabrafenib response. Baseline, you don't see any uptake in the tumors. And there is, after post-dabrafenib with 4 millicurie iodine imaging, you see uptake in the metastatic disease in the neck. I-131 whole body scan, dabrafenib for 4 weeks, repeat I-131 study. It's a pilot study, 10 patients, 6 out of 10 developed new radioactive iodine uptake in response to dabrafenib. 5 out of the 6 patients were able to receive radioactive iodine treatment and showed objective response. Another example, another study, again, a pilot study with 10 patients. This time, the agent is a BRAF inhibitor, bemurafenib. I-124 PET-CT, 4 weeks of bemurafenib, repeat PET-CT, essentially no uptake in a known sizable neck metastatic disease, turning into a FDG, turning into an iodine avid lesion with an SUV of 31. Previously, no uptake, lung lesion, now shows SUV uptake of 9. Again, this tumor here is, which is a left supraclavicular lesion, metastasis, that shows improved iodine uptake with an SUV of 5.4. 6 out of 10 patients demonstrated improvement. 3 out of 4 patients treated with radioactive iodine showed objective response. This is the study Doug already mentioned, BRAF inhibitor, dabrafenib, and MEK inhibitor together response. This is one case study, but a very well-studied case. You see the intense bilateral uptake in the lungs, as well as level 7 mediastinal and upper neck nodal disease. This is during dabrafenib and trametinib. Once you stop the dabrafenib and trametinib, the level of uptake significantly goes down. Here is the same patient comparing the immunohistochemistry for key components of thyroid differentiation and proliferation. Of dabrafenib, trametinib, NIS expression almost none versus normal. Ki-67 significantly increased and not so significantly increased. TPO, no activity versus intense activity. Thyroglobulin, no expression versus expected expression. And this is the normal hematoxylin eosin standard histopathology showing no follicular differentiation versus very nice, almost normal looking follicular differentiation. These are all very clear indicators of, these are well picked, well selected cases. They are very good for slide presentations as well. Now, this is the biologic aspect that can only be addressed by biologic means. Then both Dr. Lasser and Dr. Van Nostrand pointed out nicely, and I can't agree more. The technical issues are of great importance to improve theranostic performance. This is a simple mathematical modeling looking at the, and also when we look at the performance, one should consider false positives and false negatives. You should have a baseline understanding or appreciation of detectability limits and technical and biologic factors involved. Normal thyroid has about 25% uptake, and it's like 25 grams. If you do a calculation, remnant activity for a 1 centimeter remnant, you would have a 40 microcuries activity. In a half a centimeter remnant, you would have 5 microcurie activity. Remember, going as way back as Dr. Beerwaltes, who said there is depression of iodine uptake ranging from 3% to 40%. These numbers translate into a 17 microcuries in a 1 centimeter lymph node, and only 2 microcuries in a half a centimeter lymph node if tumor has, and on this side you see our nice cold nodule. This is to remind us what our baseline material that we start working on. The activity in a half a centimeter diameter lesion would be 2 microcuries and would be only 0.15 in a 3% uptake capacity lesion. And I posed this question several times to several good friends, including Doug. We don't have a good answer. There are few phantom studies, but they're not all that conclusive. What's the minimum detectable imageable activity using the most sophisticated SPECT-CT machinery? Is it 10 microcuries? Is it 20 microcuries per 1 centimeter lesions? I find it very hard, very difficult to believe that anything under 10 could be easily imaged, 10 microcurie. So putting these in a graphic format, red is the remnant activity. As the size increases, the red is the RAS type of lesions. By the way, RAS type of lesions tend to go remotely for and create remote metastatic disease, distant metastatic disease. It's very rare, not unseen, not unheard of, but having neck metastatic disease. Neck metastatic disease is largely as a consequence of BRAF tumors, which have the most significant depression, and they require major modulation to improve their detectability. This is an interesting case report. We talk about false positives and false negatives. SPECT-CT has the power of having the best spatial resolution. There's no doubt. It helps a great deal. You can easily identify what's in the zone of remnant, what is not in the zone of remnant. A careful interpretation helps a great deal. But only surgeons would know this better. There are ambiguous remnants that surgeons leave behind. When we're in the operating room, we're only interested in the whole operation is about recurrent laryngeal nerve. When the nerve is in danger, we don't mind leaving behind small remnants, round small remnants, which could easily be interpreted as metastatic lymph nodes because they're round, because they're focal, and because they have notable uptakes. In this particular case, you see two very intense uptake on both sides of the laryngotracheal junction. This is just left lateral to trachea, and there is another lesion that doesn't pick up radioactive iodine. This is very important because you cannot have a nodal disease that is positive in level 6 and negative in level 7. It's important to recognize remnants and not falsely upstage some of the patients. Improved detection sensitivity, I-131 versus I-124. This image belongs to Dr. Van Nostrand. I'm using it. It's courtesy. This comparison is given by Dr. Luster. We believe that I-124 has the best resolution. The most significant potential problem with I-124 is this 602 keV energy that could potentially contaminate the 511 coincidence gamma rays. There are technical ways of dealing with. We did a study in our world, Miami Thyroid Oncology Consortium. That was our first project, started in 2015. We demonstrated that sensitivity is much improved compared to 131. And also, we've done dosimetry in all the patients for doing a bone marrow dosimetry, whole body dosimetry, and target dosimetry. We find I-124 to be very easily quantitated and used. We used voxel dosimetry. We will be publishing this shortly.